Welcome to the fifth video in this series on arterial blood gas analysis or ABG analysis. I'm sorry that this video has been delayed, but as you're no doubt aware, the COVID-19 infection has been placing a huge strain on my time and my clinical practice. So without further delay, let's introduce oxygenation. But before doing that, let's introduce the term partial pressure. So as you are aware, a mixture of gases exerts a pressure. Suppose we have a situation where there are two gases in a mixture, gas 1 marked here in yellow and gas 2 marked here in red. You would notice that gas 2 is twice the amount of gas 1. Suppose these gases are allowed to mix in the container, like so. And suppose the pressure of the total mixture is 100 millimeters of mercury. You would also notice that gas 1 forms 1/3 of the total mixture and gas 2 forms 2/3 of the total mixture. So in this setting, if you remove gas 1, the total pressure would be 2/3 of your 100 millimeters of mercury. That is 66.67 millimeters of mercury. So in this example, gas 2 exerts a partial pressure of 66.667 millimeters of mercury. Suppose the situation was reversed and you removed gas 2 such that only gas 1 was remaining in the same volume. Gas 1 would exert 33.33 millimeters of mercury. That is 1/3 of the total pressure. And both gases together will exert 100 millimeters of mercury pressure. So the partial pressure in this example for gas 1 is 33.33 and gas 2 is 66.67. And you would also notice the sum of the partial pressures equals to the total pressure, which is 100 millimeters of mercury. So let's look at the definition of partial pressure. Partial pressure is the pressure exerted by one of the gases in a mixture if it occupied the same volume at the same temperature. The total pressure is the sum of all the partial pressures. In this example we looked at two gases, but suppose there are more than two gases, this would still hold true. Now why is it important to know about partial pressures to look at an ABG? If you remember your basic physics, gases diffuse down a partial pressure gradient, and oxygen and carbon dioxide levels are expressed in terms of partial pressure in our ABG report. In our atmosphere, the atmospheric pressure is roughly 760 millimeters of mercury at sea level. Saturated water vapor pressure is 47 millimeters of mercury at standard conditions. The percentage of oxygen is 21% in our atmosphere. Percentage of carbon dioxide is nearly 0%. So let us look at the concept of alveolar arterial oxygen gradient. The alveolar arterial oxygen gradient is the difference in oxygen between the alveoli and the artery. PaO2 with a capital A represents alveolar oxygen. PaO2 with a small a represents the partial pressure in arterial oxygen. And now we will introduce you to the alveolar gas equation. When air enters the nostril, it is humidified such that it is saturated with water vapor. The dry air pressure after the air enters nose is 760 millimeters of mercury, which is the atmospheric pressure, minus 47 millimeters of mercury, which is the saturated water vapor pressure. So the dry air pressure after the air enters the nose is 713 millimeters of mercury. Now, the partial pressure of oxygen when the patient is breathing in air is 713 multiplied by 21%, which is 149.73. But in a clinical setting, the patient may not be breathing 21% of oxygen. So in this setting, the partial pressure of oxygen would be 713 multiplied by the fraction of inspired oxygen. So 713 multiplied by the FiO2 would be the PO2 entering your airways, and remember the PCO2 entering your airways would be nearly zero. So this gas enters your alveoli, and from this an amount of oxygen enters into your artery. You would also notice that carbon dioxide diffuses into the alveoli, and if you would recall, we just said there is nearly zero carbon dioxide in the atmosphere. So all the carbon dioxide that is present in the alveoli has come from the artery. Now we need to find out how much oxygen has diffused into the artery. For this, we need a value known as the respiratory exchange ratio, which is basically the change in carbon dioxide divided by the change in the oxygen. For a regular mixed diet, the value of respiratory exchange ratio is approximately 0.8. Now this is based on calculations with the respiratory quotient, which you can read upon. So X is the amount of oxygen diffused from the alveoli to the blood. We said the PCO2 in the alveoli is equal to the PCO2 in the artery, and the PCO2 in the atmosphere is nearly zero. So the respiratory exchange ratio is again 0.8, which is the change in carbon dioxide divided by the change in the oxygen. So the change in the carbon dioxide here is the PCO2 minus 0, because 0 was the partial pressure of carbon dioxide which had entered the alveoli, divided by the change in the oxygen, which is X. So basically X is the partial pressure of carbon dioxide divided by 0.8. So this is the amount of oxygen that has been diffused out of the alveoli and into the artery. So the reduction in the alveolar O2 is PCO2 divided by 0.8. So the alveolar oxygen is 713 multiplied by the fraction of inspired oxygen minus PCO2 divided by 0.8. And this is known as the alveolar gas equation. So stated in other terms, PaO2, that is the alveolar partial pressure of oxygen, is equal to the atmospheric pressure minus 47, which is the saturated water vapor pressure, multiplied by the fraction of inspired oxygen, and minus PCO2 divided by 0.8. So that is how you express the alveolar oxygen partial pressure, and this equation is known as the alveolar gas equation. Now coming to the alveolar arterial oxygen gradient. Basically, once you calculate the alveolar oxygen partial pressures and you subtract the partial pressure of the arterial oxygen, this is known as the AaO2 gradient. A normal AaO2 gradient is around 5 to 10 millimeters of mercury, and it varies with age, and it can be calculated with this formula: age divided by 4 plus 4. That is the expected AA gradient for a given age. So again, AaO2 gradient means the gradient in the partial pressure of oxygen between the alveoli and the artery. Suppose you have a situation where oxygen is able to freely diffuse across the alveolar capillary membrane into the arteries and form the partial pressure of oxygen in the arteries. And suppose in this situation you have a hypoxia, that is a low PaO2. This means that the partial pressure in the alveoli of oxygen must also be low. That means there must be less oxygen coming in. So when there is less oxygen coming in, Usually in clinical practice, it is either a hypoventilation or a high altitude. So to rephrase it, in a hypoxic patient, that is a low partial pressure of arterial oxygen with a normal AA gradient, implies that the diagnosis is either hypoventilation or high altitude. So a hypoxia with a normal AA gradient usually implies hypoventilation or high altitude. Causes of hypoventilation includes CNS causes like brainstem stroke or trauma, or certain drugs which suppresses CNS function like opioid overdose, COPD, neuromuscular diseases, chest wall deformities, and obesity. Now let's look at another situation where there is a barrier preventing oxygen from freely diffusing into the arteries. So in this situation, the PaO2, that is the arterial oxygen partial pressure, is low, but the alveolar oxygen is normal or high. So in this situation, the AA oxygen gradient is widened. That is, there is much more oxygen in the alveoli than in the arteries. So in a situation of hypoxia where there is a widened AA gradient, it implies there is an intrapulmonary shunt, a VQ mismatch, or a diffusion limitation. So to restate it, a hypoxia with the widened AA gradient implies intrapulmonary shunt, ventilation perfusion mismatch, or a diffusion limitation. Let us look at examples of pulmonary shunt. Pulmonary shunt can be caused in a pneumonia, pulmonary edema, collapse or atelectasis, hemorrhage, contusion, or abnormal arteriovenous connections in the lungs. Let us look at what happens normally. Here you can see representations of the two lungs, the left and right. You can see the airways, and the outer circle represents the pulmonary artery on the left and the right side, which joins together to form the pulmonary vein at the bottom of your picture. You can also notice that the airways carry air into both lungs. So what would happen normally is deoxygenated blood would flow through the pulmonary arteries, and when it reaches the lung, it would be oxygenated, and this would drain into the pulmonary veins. Now suppose you have a situation like this where the entire right lung is filled with secretion, or in this case, let's say it is a consolidation. So you would note that the air entering the right lung is now obstructed due to the secretions or the consolidation here. Now what would happen is the blood would go through the pulmonary arteries to the right side, but you can notice because there is less air coming through to the right side, the blood flowing through the right lung remains deoxygenated, whereas the blood flowing through the left lung gets oxygenated. And in the pulmonary vein you have mixed blood which is not fully oxygenated. So this is an example of an intrapulmonary shunt. And you can notice here, no matter how much oxygen you would give this patient, the blood flowing through the right lungs remain deoxygenated. So supplemental oxygenation will not increase the partial pressure of oxygen. So again, a shunt is hypoxia with the widened AaO2 gradient, and larger shunts, especially more than 20%, respond poorly to oxygen supplementation. Let us look at VQ mismatch or dead space effect. A good example here would be pulmonary thrombus or embolism, emphysema, shock. So let us look at the pictorial representation. So this is the same situation as before, but here you can notice that in the right pulmonary artery there is a thrombus which occludes blood flow through that side. You can also notice that the right lung is well aerated. So let us look at what happens. When blood flows through both sides, The thrombus on the right side will occlude the blood flow, and on the left side the pulmonary arteries oxygenate normally because the left lung is normal. In this situation, you can note that most of the blood is shifted away from the right lung into the left lung. So the blood remains well oxygenated. So in this setting of a VQ mismatch or a dead space effect, there is a high AaO2 gradient and it responds well to oxygen supplementation. Another example is a diffusion limitation, which happens in interstitial fibrosis when the alveolar capillary membrane is thickened and the diffusion is impaired. So in diffusion limitation, there is a high AaO2 gradient which responds well to oxygen therapy. So let's organize our thoughts. In a case of hypoxia, the AaO2 gradient may be normal or high. A normal AaO2 gradient would imply hypoventilation or high altitude, but clinically, usually it is a hypoventilation. In a hypoxia with a high AaO2 gradient, it could either be a shunt, a VQ mismatch, or a diffusion limitation. Shunts generally respond poorly to oxygen. A VQ mismatch or a dead space effect responds well to oxygen, and diffusion limitation also shows good response to oxygen supplementation. Let us look at a few examples to illustrate our point. A 75-year-old lady with recent history of head and neck surgery presented to the ER in a comatose state and hypoxic. Her investigations were normal except for the ABG, which is shown here. You may note that she was on 40% of oxygen when this ABG was taken. The pH here is 7.15. The PCO2 is 150. Well, actually it is more than 150, but the machine can only read up to 150. So let us assume that it is 150. The PO2 here is 75, and the bicarbonate is out of the range of the machine. So let us ignore that bicarbonate for now. So if you would recall in the first videos, this is a chronic respiratory acidosis. We will not go into detail because we will only focus on the oxygenation in this video. The AaO2 gradient here, this is the alveolar gas equation, which would be the FiO2, which here is 40. This is represented in decimals, so here it will be 0.4. The atmospheric pressure minus the saturated water vapor pressure minus the PaCO2, which here is 150, divided by respiratory quotient, which is 0.8. So it will be 713 multiplied by 0.4, which is your FiO2, minus 150, which is the PCO2, divided by the respiratory quotient, which is 0.8. And this is 97. So the alveolar oxygen partial pressure is 97 and the arterial oxygen partial pressure is 75. So the AA gradient is 97 minus 75, which is 22. The expected AA gradient for the age is 22.7. So this is a normal AA gradient. So in this case, it is a hypoventilation. You can theorize that in this case there is some brainstem ischemic insult which has resulted in the hypoventilation. Let us look at another example. A 66-year-old man presented with dyspnea during the COVID-19 pandemic was found to have pneumonia. His ABG was as follows. You may note that the fraction of inspired oxygen here is 90% or 0.9. The pH here is 7.4, the PCO2 45, the PO2 32, and the bicarbonate 26.1. So the acid-base status here is normal, but the patient is hypoxic. The alveolar oxygen partial pressure here is 713 multiplied by 0.9, which is your fraction of inspired oxygen, minus 45, which is your PCO2, divided by 0.8. And that would give you an alveolar partial pressure of 585 millimeters of mercury. And the AaO2 gradient would be 553. The expected AaO2 gradient for this patient is 19. So there is a widened AA gradient. So this is an example of hypoxia with widened AA gradient. And we noted that this patient was on 90% oxygen, but there is a poor response to the oxygen supplementation because the partial pressure of oxygen is still low. So this is an example of a high AA gradient hypoxia which responds poorly to oxygen supplementation. So this is an example of a shunt. In this case, you can theorize that the patient has ARDS or a large pneumonia which causes the shunt. Another example, a 90-year-old lady was brought to the ER in a comatose state. Her ABG is as follows. So the pH here is 7.076, the PCO2 is 128, the PO2 is 61, the bicarbonate is 37.8. Note that she was on 36 percentage of oxygen, so her FiO2 will be 0.36. So the AaO2 gradient here is 7.2. The expected AA gradient here is 26. So this is a normal AA gradient. So this lady has a hypoxia with a normal AA gradient. So this is an example of a hypoventilation. We will look at the clinical relevance of finding a hypoventilation. So hypoxia here is due to inadequate ventilation, that is, the patient is not breathing adequately. Supplementation of oxygen would appear to correct the saturations in the ER, but ventilation is required. Usually for these patients, patients with pure hypoventilation, they usually do not require oxygen supplementation. Correction of the saturation only by oxygen supplementation and without ventilation may be dangerous in these patients because the patient is not breathing. There may be carbon dioxide accumulation and it may lead to respiratory acidosis and eventual death of the patient. For your other cases where the AA gradient is widened, it has to be investigated accordingly and treated on a case-by-case basis. Let us stop for now. We will take a problem-based approach in the next video. We will look at a few problems and try to interpret the ABGs. In a later videos, we will look at the limitation of our current approach and pitfalls in ABG that are commonly encountered in clinical practice. Thank you for watching the video, and please consider subscribing and liking the video, and please do add comments in the comment section below, especially if you have any suggestion for future videos. I will also try to put up a few videos on the current coronavirus pandemic, especially focusing on the pathology and the treatment options available currently, looking at the evidence base that is currently available. Again, thank you for watching my video. Please like and subscribe if you like the video, and please comment with any suggestions below. Thank you.